This conference will now be recorded.
Hello, everyone. Welcome to today's training on Behavior Skills Training, or BST. I'm Dr. Aclan, and we also have Dr. Davila here to present the material to you. We utilize Behavior Skills Training, or BST, with how we interact with our behavior technicians, how BCBA supervisors and clinical directors interact with case managers, as well as how we interact with families, especially when we're teaching new skills. So the important piece about BST is to find effective caregiver training essential to an ABA-based program. When we talk about caregiver training, we're not just talking about parent training in our sessions, but also caregivers as behavior technicians providing services to our clients. And the reason for this is because our main goal is not just to teach skills, but also to create a maintenance and generalization of skills such that the client themselves or the person that we're training develops the skills and can carry them out on their own. So with that said, caregivers and our BTs will need to utilize certain tools and strategies in order to implement our protocols. Part of this too, on a mentalistic component, is that caregivers need to build a form of confidence in order to implement their clients' programs. So many times our BTs as well as our parents may avoid implementing a BIP or following through with a skill acquisition program, not because of timing or anything like that, but the response effort or even the clarity or understanding of how to implement the protocols. Sometimes our protocols are easier written versus carried out. So we have to find ways that our protocols not only are clear for people to understand written, but also can be carried out for another person.
Okay, Dr. Aclan, would you like for me to do this one here? Awesome. So, hey everyone, this is Dr. Davila, and like Dr. Aclan was talking about, the behavioral skills training, the BST model is, basically a training package, a treatment package that has different components. The written and the vocal instructions tends to be the one component that a lot of clinicians in our field overutilize. Think about, when you sit down for a training and you just get a bunch of PowerPoint slides presented to you. That's more or less what this particular, component is about. It's more or less considered a didactic-based kind of training that, unfortunately we don't have the research here, but there's a lot of research that shows that it's not very effective at training. So that's one of the first components there. The second one is modeling. Now, modeling can be in-person modeling, but you can also have video modeling. So we're going to talk a little bit about these two different types of components later on. We're actually going to have some videos for you to see the difference between video modeling and in-person modeling. The third one is rehearsal, and that's also considered role play. So whenever you have an opportunity to practice a particular program or a behavior intervention plan, strategies outside the session time with, you pretending to be a client and the other person pretending to be an instructor or behavior technician, so on and so forth. That right there is considered rehearsal and role play. It's another really effective way to also, as much as possible, rehearse and practice those skills. The last one right here is so important. That this is feedback. Feedback is one of the most essential components for the BST model, because feedback allows people to know whether they're actually heading the right direction or where they need to make an adjustment to how they're implementing something. So when you're using these different components, you're obviously using this to train new skills, because when you're working with a behavior technician or a caregiver, there's some type of skill deficit there that is going to be the focus when you're implementing this particular training package. And like any skill, there has to be some type of mastery criterion to basically determine, what particular intervention or components are working. There's some parents that are going to respond well, or some behavior technicians that are going to respond well to certain components. So that's where your data is going to be so essential to be able to determine whether we need to make some adjustments or, if we're heading the right direction. Okay, so the next thing here is that, for sure, the whole aspect of the BST model allows a learner to acquire skills through various modes of presentation. And I always imagine myself when I go through a training that one of the best ways that I've actually experienced training is to have that sense of that you're getting different, ways of information, right? It's not just one particular, once again, lecture of how to do something. Rather, you get an opportunity to get some hands-on training and get that feedback. So for sure, the whole aspect of getting different or various modes of presentation is so helpful. Also, the research shows that learner acquires skill in short amount of time and maintains skill compared to other training methods when you use the BST model. And also accounts for generalization of skill and is also known as a train-the-trainer model, which I'm sure some of you guys have heard about. This is so essential. And what's interesting too in this particular presentation is that your directors are also going to get the opportunity to do some, rehearsal and some feedback as well. So everything that goes in regards to how to implement, a new skill or how to, practice something, it does require the entire aspect of the components and the treatment package that we're reviewing right now.
So now when we talk about the implementation of BST, in the beginning, the trainer is responsible for a majority of the work. So if you think about it, when you're starting to learn a new skill, you as a trainer are going to be doing a majority of the work because you want to be the one to demonstrate what is supposed to happen. And then the responsibility of the trainer is going to decrease as the learner is acquiring these skills. So in the beginning, the trainer is going to present each of the teaching components. So what that means is if you have a BIP, if you have a skill acquisition program, you as the trainer are going to be responsible for teaching each of these components using each of the steps that Dr. D had talked about before with the written instructions, modeling, rehearsal, and feedback. Now, although in the BST model, feedback is usually the last step, it's actually embedded in each of the steps before. So for instance, if you're going over a written protocol and you or the learner asks questions, you provide either the answers to the questions or clarification to any uncertainties that they have. So that's a level of feedback. You might also ask the learner questions of how they might be comprehending the protocol, and if they're comprehending it not in the same route that you are expecting it, you could provide feedback to ensure that clarity. You also want to make changes to the learner's exposure to the teaching components. What that means is teach in multiple exemplars. At the end of this training, your clinical director will be walking you through different scenarios, either ones that you bring up or ones that they give to you to achieve more efficient and effective acquisition. With the BST model, multiple exemplars are key because it doesn't just show us what to do in one situation, but provides us with a continuum of various situations that we might be able to utilize these skills. So how is it that each of these steps are going to be broken down? So the first one is to describe the purpose and related teaching intervention procedures in detail. So let's pretend like we're talking to a parent and we want to work on how to decrease tantrum behavior. So I might say something like, to see Johnny's tantrum behavior decrease outside a session, I will be working with you on implementing the intervention we're using in session. So at this point, I'm explaining to, in this case, a parent that what I'm doing is going to transition over to them. I want the parent to do what I'm doing. I will show you the intervention protocol. I will model it for you and we'll be able to rehearse it. This step is now showing the parent or the learner what my expectations are. It's not just that the parent's going to be sitting in session and watching what we're doing. It's also going to be that, yes, they could watch, but they're going to be responsible for implementing and performing the steps of the interventions. Once you feel comfortable with the protocol, I will have you implement it without my help. That last step shows that the end result is that we want the learner to implement the protocol without our assistance. Again, back with what we discussed, most of the effort in the beginning is on the trainer, and then we're going to fade out that effort and transfer that over to the learner. So Dr. D, would you like to talk about the written instructions?
Yes, for sure. So with regards to the written instructions, it says here that directly reviewing any related written documentation. So you're reviewing whatever intervention plan or task analysis you created for a particular school that you're going to be teaching. So here the trainer is going to present the learner with any written visuals or protocols. The learner will review the documents with the trainer, and basically you would want to encourage some asking questions during that process as well. The trainer will elaborate and provide examples to apply, basically the whatever intervention you're going to be implementing with the client. So it's a lot of, once again, instructions, written instructions or vocal instructions. And once again, this is one of the first parts of the BST model. And it is, once again, really important for the team to, definitely understand that this is not the only step that you want to implement. I've had experiences where I've, been given a document and say, hey, just read it, and now you're going to implement this. That's it. That's your training. In reality, that's not, the adequate training, but nonetheless, it is still part of the BST model, and it's one of the components. Okay, so in this video here, what you're going to be observing is you're going to be observing the first component, which is the written instructions component, and you're going to see me right now providing a vocal instruction to the behavior technician there. And you're going to see how I deliver the SD, which is basically just go ahead and read this document here and go ahead and implement an error correction procedure. All right, Juan, so please make sure to read these instructions here and make sure to follow all the different steps to implement error correction with Edwin. Okay.
Okay. What is it? Marker. No, I'll try again. What is it? Pen. Pen. Very
good. Okay. So in that particular video, one of the things you were able to observe there is that after I provided the instructions to Juan, that's where I stopped the entire process of providing more information. I just provided the written instructions. I delivered the instruction to present this particular intervention or this particular procedure. And this right here, once again, is the first component of the BST model. All right, Juan,
All right, so the next phase is a model. So you might either model it directly, which we call in vivo, or you might use a video model. Now within ICANN-B, we could use video modeling in various ways. One is reach out to your BCBA supervisor or clinical director and ask if we have a video on the skill you would like to present to the learner. We might have it on file. If we don't have it, you can reach out to the clinical director and ask if we can create a video, and you might have Dr. D, myself, Juan. It could even be you all creating the videos together. We have various resources to create these, and they don't have to be a big production. But essentially, with the video documentation or video model, it's similar to the written instructions in that you're going to present the learner with the visual of the desired behavior. What that means is you're going to show a video of what the step is supposed to look like. Just like the written instructions, you're going to encourage the learner to ask questions and seek clarifications before implementing the skill. Along with that, the trainer is also going to elaborate and provide examples to apply the documents or the training to the client's behavior. Now, with that said, even though it might be one video, there might be multiple exemplars. There could even be possibilities where you're watching the video multiple times, where you're pausing the video with the learner to show specifics of the protocol, such as pausing the video and saying, oh, did you see how the SD was delivered? Or did you see how the person gained attention before implementing the procedure? So here's going to be a video of showing a video model. Ironically, here's a video model of video modeling. So Dr. D is going to show Juan a video, and Juan is then going to take that video and implement that protocol with Edwin.
All right, Juan, so I want you to review this video real quick. This is the error correction procedure you're going to be implementing with Edwin, okay? And whenever you're ready, you can get started.
Got it.
Okay, perfect.
Okay. All right. What is it? Pencil. No, try again. What is it? Pen. Awesome. All right, well done.
All right, so in this case, Dr. D showed Juan a video. Juan watched the video, and then he implemented the steps with Edwin. So that would be video modeling.
All
the
right,
other one, oh, go for it.
Oh, sorry. So number 3 is basically here we have the model, which is the implementation once again with the caregiver acting the role of the client. So this allows the trainer to model what to do or how to implement the protocol without having the client present. The trainer can provide dialogue while implementing the protocol. So Dr. Aclan, is this an in vivo model intervention here or perfect? So yeah, this is an in vivo that you're going to see there. Perfect. So this is going to be the in vivo. So here you're going to see basically how, I'm going to be implementing the intervention while Juan is going to observe me implement. And then after that, he's going to have a chance to implement it. Oh, actually, here's the example here. So it says here, pretend you're Johnny, play with your toys. When I say clean up your toys, start engaging in the tantrum as you have seen. This is what you will do when you see this behavior. Now again, pretend you are Johnny playing with his toys. While he's playing, say something like this. When the timer goes off, you will clean up your toys. So you can actually implement the modeling with the person. You can actually with the behavior technician, or you can also implement the modeling, which I actually like. Once again, modeling when I'm working in the field. I like to model intervention in vivo because that allows the person to see how they would actually implement it with the client. So you can either do it with both options. Right now that a lot of you guys are working with your telehealth and doing a lot of telehealth supervision, you can do some of this as well on the computer, where you can be able to do some modeling with, some modeling with the person, with the behavior technician outside of session time or during session time when there's a break. So there's different options for that. Okay, so here comes the in vivo modeling. So this is going to be me presenting, showing Juan how to implement this particular error correction, intervention here. All right, Juan. So in this situation, I want you to observe really closely how I'm going to run the error correction. Okay, so here we go. Okay, what's this? A marker. No, try again. What's this? Pen. Awesome. Good stuff. All right, you got it?
Yes.
All right, perfect. Okay, there you go. So that right there, you're able to see that I was able to show Juan, model Juan the intervention, and then he's going to get a chance to implement it. So that's what would be considered in vivo model.
Now, an important piece here is with modeling, regardless of if you're using video modeling or if you're using in vivo modeling, it's important to switch roles. And by doing so, now you're going to allow the learner to implement the same steps that you did. Now, when you're rehearsing, it's important that at times you might not want to have the client there depending on what the skill is, because you might want to provide corrective feedback with the rehearsal. So when you insert, let's say, the client who might then throw out variables where they might be distracted or whatnot, it might be something that you take a step back and say, okay, BT or parent, you and I are going to rehearse this by ourselves. And then once you see that the individual receives the corrective feedback and can implement the steps to a certain criteria, then you will have the client come back in. So here with rehearsal, the trainer becomes the client. So if Dr. D and I were providing BST and he was my trainer and I was the learner, I would implement the protocol and Dr. D would pretend to be the client. And so I then, as the learner, will act as the caregiver implementing the protocol. So in that way, we get to reverse our roles and I get to implement the steps. And then at the end of that, Dr. D will provide feedback. So if you see again, even though when we look at BST, feedback is usually the last step, it's actually embedded, like I said, within each of the steps. Because again, feedback is key. So here's a video of Dr. D and Juan practicing rehearsal. So if you look too, Edwin is no longer in the room, I guess, in this case, because this is a time where Dr. D and Juan are just spending the time working on the steps of the protocol.
All right, Juan, so in this situation, what we're going to do is I'm going to role play with you. I'm going to pretend to be the client and you're going to be the instructor. We're going to implement error correction with that program that we talked about. Okay? Okay. So here you go.
All right. Jose, what is it?
Marker.
No, try again. What is it? Pen.
Well done, Juan. That was really well done.
Okay. Thank
Good.
you.
And if you see here, Dr. D provide feedback to Juan immediately with the well done. All right, so Dr. D, bring the step.
Number 5. So number 5 is basically the feedback. I believe Dr. Aclan, this is going to be the feedback, that Dr. Aclan was referring about. So in this situation, you're going to observe the caregiver or the behavior technician implement the protocol with the client, and then basically in this example, the caregiver sets up a situation at home for Johnny to engage in a tantrum. So there's going to be an opportunity for that episode to occur. And what we're going to see here is that in the process of the instruction, in the process of delivering the error correction procedures, there's going to be some errors there, and you're going to see me providing some type of corrective feedback when Juan makes the error. And I want you to all pay very close attention to how I do it. I think that a lot of times the sensitivity of how you provide the feedback is very important, because sometimes people may get really we can get upset about the whole aspect of getting feedback and all that. So one of the things that I always try to do is try to do it in a very calm and very, very tactful manner. So, in this case, Juan would not feel intimidated by my feedback.
All right, what is it? Crayon. What is it? Crayon.
So in that situation, what we need to do is we want to make sure we close the trial. So when Edwin responds incorrectly, you're going to close that trial by saying, no, try again. And then you're going to present instruction again. And then immediately you're going to provide the prompt. Okay, so let's go ahead and try again.
Okay, here we go. What is it? Crayon. No, try again. What is it? Pen. All right.
Good stuff. All right. So then afterwards, I said, good stuff. I could have probably been more detailed about the good stuff and say, hey, great job implementing the error correction procedure well. So those are things that you can implement, but you saw how the corrective feedback occurred right after the error. there is possibility sometimes for you to do that, but there are also going to be scenarios where you can't do that. So you might have to wait for, you know, an opportunity where there might be a break to provide that feedback. But nonetheless, feedback is so essential, especially immediate feedback after you observe some area that needs to be improved on.
And I think that leads us to a very important piece about feedback. It is an uncomfortable piece, especially when it comes to caregivers like BTs or parents. They have a lot that they're doing in a short amount of time. I mean, even parents, they have a lot that they're doing. They're not just focused on our client. They have other things to do, you know, during and outside of our session. So it's easy for us as trainers to avoid giving feedback, but it is essential to what we're doing. So no matter how uncomfortable it is, the importance of feedback is actually going to give us the results that we want to see. So just like what Dr. D was saying, is that the feedback that we provide to our BTs, to our families, should be tactful. It should go back to the behaviors at hand, because feedback identifies what the learner must correct to prevent errors in the future. It's also something that we could reinforce, just like when Dr. D was telling Juan, nice job, or you got this, or you did this. You know, one thing is identifying what is appropriate feedback. And then also too, what can be done so that next time it's implemented, there are little to no errors being done. Because at the end of the day, the more feedback we provide, the more success we're going to see the families, the BTs, and the clients make. And remember, we can't be in the homes all the time. So, you know, no matter how uncomfortable it is to provide feedback or to find pockets of time to give someone feedback, it is something that it's part of how we're going to be successful. Feedback allows us to work with the learner to identify their own behaviors. So with that said, they're not going to become dependent on us. They will then be able to implement it on their own, because they will see what the expectations are. They will see what they're supposed to do. So again, it promotes generalization. Keep in mind that the less work we have to do, the better, because of the fact that that allows us to then help out other families. That then allows us to identify more skills that the learners can acquire when we're with us. So feedback is uncomfortable, but if we have multiple opportunities, that discomfort goes away, because then you get used to it. All right, Dr. D, if you want to take this home for us.
All right, let's bring it home. So notes and tips. So throughout the BST process, the trainer provides feedback on the learner's performance. So the focus is the learner's performance, nothing personal. Once again, one of the biggest tips I give you guys is to be very, very clear as to what you're trying to teach. All right, so before you start saying anything or navigating through the process of trying to provide feedback or implementing BST model, know what you're going to teach, okay? Feedback should be immediate, like I said, if possible. There's going to be scenarios where it's going to be not possible to do so. There's going to be scenarios. I remember working as a supervisor where I had to literally go on to maybe a role play or a model, because the client, specifically the model, because there's a client that was engaged in a problem behavior. I saw the behavior technician struggling, so I would have to go in there and try to model for the person how to do it. So there can always be a combination. It doesn't have to be very, very much about step 1, step 2, step 3, step 4, step 5, but rather it's more about you being able to gauge the situation and see what would be appropriate in that scenario. After feedback is provided, the learner will set up another opportunity to practice and correct any errors. So like the example you saw there with the feedback, what would happen afterwards is that I would allow Juan to implement the intervention again, or to implement the error correction. And then I would basically, just see, right, if the feedback help improve its performance in the next trial. So it's like any skill, the more trials, the better the person's going to be performing. So make sure to keep that in mind, that if you provide feedback, give the person a chance to do it again so you can see whether their feedback was actually effective or not. The once the learner has met the mastery criteria, training is faded and is left to implement protocols independently. One of the biggest things you want to do, and this is an error that I used to make too, is that I used to be very hands-on. When I used to go to the field, I used to be very, very hands-on. So one of the things you want to make sure you start doing and also keeping track for yourself is how much are you doing? How much fading are you also doing? And how much independence are you providing to your behavior technician? Because if you overly prompt during your supervision sessions, your behavior technician is going to basically have very minimal opportunity to also learn and to also incorporate some of the skills that you're trying to get them to implement as well. Lastly, the trainer will set up follow-up observations and training to support the learner. So once again, your data is going to be so essential here. I want to emphasize that you know, your behavior technician is engaging in behavior, and like any behavior, we can track it, right? And we're going to be able to document that in their own performance evaluations, where they're actually improving in future observations and supervision sessions. So these are some of the notes and tips that we have for you guys. Thank you so much for you know, listening to these to watching and listening to this training. So I hope this is helpful for you.
Thank you guys once again for being here. As of right now, after this recording, your clinical director will be leading a discussion to answer any questions, as well as presenting any scenarios for you all to ensure that this then generalizes from the training over to your clients. Have a good day, everybody.
Bye.